Oral care for patients with chronic kidney disease is a very important subject. Unfortunately, it traditionally has poor exposure in the renal field. You may question why you need to know about the mouth. After all, you are not dentists. However, in medically compromised patients, you often see signs and symptoms of systemic disease or as a side effect of the medication used to manage it. You look after a very vulnerable group of patients with chronic kidney disease, and we know that the number of these patients is increasing as the population ages. Approximately 90% of this group will have an oral sign or symptom linked to their renal disease. A significant number of these patients will not have a dentist. This can be due to issues such as cost, access, chronic fatigue, and the desire to avoid further appointments with healthcare professionals. There may also be concerns that the dentist is not fully aware of the implications of chronic kidney disease and hence cannot manage them properly. However, you see these patients on a very regular basis. As such, you have an ideal opportunity to check their oral health and a really important role in screening. You may also implement prevention and manage some of these lesions, signs and symptoms. So what signs or symptoms of renal disease will these patients have? Nearly 60% may have active gum disease. 50% may have a dry mouth. 1 in 5 may have no teeth at all, and 1 in 5 may have oral pain. Worryingly, a quarter of patients never brush their teeth, leading to a high risk of oral infection and sepsis. Importantly, a dry, painful mouth and no teeth have a significant impact on nutrition. Oral care is also of importance in renal transplant patients, with studies reporting between 1/3 and 2/3 of patients having oral signs and symptoms. The most frequent signs are overgrowth of the gums, also known as gingival hyperplasia. Red patches or white, thick keratotic patches may also be observed. The risk of precancerous or cancerous lesions is higher. 1/3 of these patients also report a dry mouth. Again, of concern, as reported by several studies, oral hygiene is poor in this cohort, and most patients do not visit the dentist after renal transplantation. Your role in providing initial screening and encouraging patients to see a dentist is vital. There is another aspect which needs to be considered, and that is the possible bidirectional relationship between chronic kidney disease and gum or periodontal disease, mediated by diabetes and hypertension. This is because inflammatory markers linked to endothelial inflammation are also implicated in both gum or periodontal disease and systemic diseases such as diabetes, heart disease, systemic infections, and pneumonia. This relationship has more recently been suggested in dementia, resulting in an earlier age of onset and more rapid progression. Furthermore, studies have suggested that individuals with CKD who also have periodontal disease have a higher risk of mortality, perhaps again mediated by inflammatory markers and formation of plaques within blood vessels. This mirrors the link between gum disease and increased mortality in the general population, and has been reported in a very powerful study with over 10,000 study subjects. All of these factors confirm that there needs to be a strong focus on prevention of oral disease. Hence, screening for oral disease is very important. In order to do this effectively, renal clinicians who see these patients more frequently should have a basic understanding of the oral and dental aspects of CKD so that problems can be identified early and managed appropriately. The result will be a reduction in risk, oral discomfort, and improved quality of life in these patients. The rest of this lecture provides the renal team with a guide as to how to screen patients for oral signs and symptoms, what to look for, and what to do about it. In this context, let's consider a couple of scenarios. Firstly, a patient who presents to you on clinic complaining that they can't eat because their mouth is very sore. You take a pen torch and discover the lining of their mouth looks very red and irritated. What do you do about it? Another patient then comes in and complains their mouth is very dry. Again, when you look inside their mouth, their tongue is very dry and there is no saliva pooling in the floor of the mouth. Why does this occur, and how would you manage it? In order to be able to answer these questions, I will describe some of the oral complaints and potential changes in the jawbone, teeth, incidence of oral disease in these patients, and detail what to do about them. In terms of oral complaints, patients predominantly complain of a bad taste and a bad smell. These can have a significant impact on eating and nutrition and also social interaction. The bad taste is often described as metallic or bitter. A potential cause is the conversion of the high urea content in the saliva to ammonia and carbon dioxide by the action of bacterial urease. Other potential contributing factors are the metabolic disturbance in CKD patients, or as a side effect of medication. Reduction in salivary flow or change in composition of the saliva and also low levels of zinc have also been implicated. It has been noted that in children there are a reduced number of taste receptors. Bad taste can significantly affect nutrition and is a priority for patients. Indeed, taste disturbance is ranked in the top 10 priorities for patients and caregivers. It can result in patients craving salty foods, which is of course of concern when salt intake should be restricted. Management of taste disturbance can be challenging. Zinc sulfate tablets, 220 milligrams, given twice daily, have been suggested to improve taste sensation in some patients. The other major concern for patients is bad smell from the mouth or malodor. This may be caused by uremia, in other words, ammonia release, leading to a fishy or urine odor. Poor oral health and gum disease have also been implicated, and underlying diabetic ketoacidosis can contribute. Dietary factors such as high garlic intake should also be considered. Xerostomia is a frequent symptom of patients on dialysis and is due to reduced fluid intake, dehydration, uremic involvement of saliva glands, medications such as antihypertensives and diuretics, and occasionally mouth breathing. Significantly, it can cause problems with eating, drinking, swallowing, speaking, and also predisposes to higher rates of dental caries or decay. Dry mouth care involves advice generally of frequent sips of water, but of course if fluid restriction is in place, hydration of the mucosa with a sponge stick or moist soft toothbrush may be preferable. A dry mouth gel may be of help in addition to lip balm or Vaseline on the lips, particularly at night before the patient goes to sleep. Because of the lack of saliva protecting the lining of the mouth and the teeth, it is even more important to advise the patient to keep the mouth clean. Unfortunately, some patients use sweets to stimulate salivary flow, and they should be advised that this will significantly increase their dental decay risk. Sugar-free chewing gum is preferable. There are many agents available across the world to substitute the saliva or stimulate it. What one should remember when selecting one of these is that some are preferable for dentate patients because they contain fluoride, such as Luborant and Saliva Orthana, but glandazane should not be used in patients with teeth because it's very acidic. Some patients may prefer a saliva replacement gel such as Oral Balance, which they can rub on their gums. Stimulants such as Orthina lozenges are of limited value because they do not contain fluoride. Salivex pastils can be acidic and are generally better accepted, but again do not contain fluoride. Various changes have been observed in the jawbones of patients with CKD. These include a reduced thickness of the cortical bone and demineralization. The trabeculation of the bone may be decreased and a ground glass appearance present. Premature bone loss, radiolucent or lytic lesions may be present. There is an increased risk of fracture and also brown tumor. These jawbones need to be considered when surgery is undertaken on the bone. Increasingly, patients ask about dental implants. Complications from CKD, including hypophosphatemia, hypocalcemia, hyperparathyroidism, and vitamin D deficiency, will impact on bone structural integrity. Additionally, dental implant treatment is challenging due to medical comorbidities, including the risk of infection, bone lesions, bleeding risk, and altered drug metabolism. Careful evaluation and planning and close liaison with the dentist is required. In addition to these signs and symptoms and bone changes, mucosal lesions have been described in CKD patients. Uremic stomatitis is very severe but rare. Ulceration, infections, petechiae, ecchymoses, white patches, oral hairy leukoplakia, and malignancies have been described. Uremic stomatitis is possibly a consequence of raised levels of ammonia compounds formed through the action of bacterial ureases. There are 4 types: ulcerative, hemorrhagic, non-ulcerative or pseudomembranous, and hyperkeratotic. Of concern because the mucosa is not intact, secondary infection of the mucosal lining of the mouth is common. Management includes a control of the urea concentrations, and uremic stomatitis may resolve within a few days to 3 weeks after renal dialysis. Control of pain may involve the use of ice chips, analgesic gels or mouthwash, and the removal of superficial plaques. A uremic plaque has been described as dislodged and subsequently obstructing the patient's airway, leading to death. Oral infections include oral candidosis and hepatic infections, although the latter is more common in immunocompromised transplant patients. Management of candidal infections may involve an oral swab, although delays in reporting mean that oral examination and clinical diagnosis are generally of more benefit. Antifungals such as nystatin, miconazole, fluconazole, and occasionally in immunocompromised patients itraconazole and ketoconazole may be used. It should be remembered that lozenges and pastilles are generally unsuitable due to the reduced availability of saliva to dissolve them. Herpetic infections are also observed. Now, treatment. X-rays may show that the ligament around the teeth in relation to the root may be widened. Dental erosion is due to multiple factors. It can be due to xerostomia, gastroesophageal reflux disease, vomiting, and also diet, particularly when acidic sweets are sucked to eliminate bad taste or to stimulate salivary flow. Erosion can cause significant dentine hypersensitivity, and this may impact on eating and drinking. It may also impact on poor aesthetics. Management includes managing the xerostomia, dietary advice to avoid the sweets and acidic foods, and control of gastroesophageal reflux disease. Fluoride supplementation is also helpful in reducing sensitivity. In terms of gingival hyperplasia, the primary focus is to improve oral hygiene, as the effects are very much diminished if deposits are not present. The patient should be advised to see the dentist and/or hygienist regularly for cleaning or debridement. If it does not resolve sufficiently, surgical reduction of the overgrowth may need to be considered, or medications also changed. A lower dental caries prevalence has been associated with patients with chronic kidney disease as identified by a systematic review where 6 articles met the inclusion criteria. There was weak evidence of a lower incidence, but the plaque pH correlated directly with salivary urea nitrogen concentration, which was more significantly alkaline in patients with chronic renal failure. It is, however, important to remember that other factors may play a significant role. Renal patients may be unable to access dental care due to cost, and xerostomia may in fact increase the rate of dental decay. In terms of dental calculus formation, this occurs because dental plaque, if left undisturbed for 2 days, will start to harden and turn into calculus or tartar. This cannot be removed by a toothbrush. Higher calculus rates are reported in renal patients and are associated with higher concentrations of phosphate in the saliva. In terms of loss of teeth, it's important to know the maximum number of teeth that patients may have. This is 32, in other words 8 in each quadrant. If teeth are lost due to poor oral health or periodontal disease, this can result in problems eating and with nutrition. Poor aesthetics may resulting in lower self-esteem and lower quality of life. The impact of periodontal disease on physical and psychological domains in long-term hemodialysis patients has been investigated. This confirms that these patients have a higher prevalence and severity of periodontal disease, which may lead to tooth loss. The gingival and periodontal index was associated with a low quality of life, both on physical and mental components. Patients should be advised to visit their dentist and/or hygienist at least every 3 to 6 months. A non-foaming toothpaste may be of benefit for those patients with a sore, painful mouth. A higher fluoride toothpaste and mouthwash is particularly of benefit if there is dentine hypersensitivity and discomfort from the mouth in relation to cold drinks and food. It also helps to prevent dental decay. Chlorhexidine mouthwash is useful if a patient has significant gum disease. Encourage patients to brush their teeth at least twice daily, once in the morning and last thing at night. They should use a small pea-sized amount of toothpaste and spit, not rinse, after brushing, as this keeps the fluoride from the toothpaste on their teeth and helps to maintain its benefits. Similarly, they should not eat or drink for 30 minutes after brushing and not at all after brushing in the evening. In terms of toothpastes, non-foaming toothpastes do not contain sodium lauryl sulfate, the foaming agent, and patients with uremic stomatitis or mouth ulcers may benefit from this, but don't use it in patients with a dry mouth as it can make it worse. There is some evidence that lactoperoxidase toothpaste inhibits cheirogenous bacteria and can be of benefit for patients with a dry mouth, but further controlled studies are needed. Most toothpastes contain at least 1,350 parts per million fluoride. Higher fluoride toothpaste can be prescribed for patients with a dry mouth and sensitive teeth and can reduce the effects of erosion. Chlorhexidine gel or mouthwash can be used in patients with a profoundly dry mouth. There are studies which advocates its use in a custom-made applicator for 5 minutes every night for 14 days. This should be done under supervision of a dentist and repeated every 3 to 4 months. It has been shown to significantly reduce the Streptococcus mutans counts, which are implicated in dental decay, but may also be of benefit for patients with gum disease. Alternatively, patients can use chlorhexidine gel or mouthwash for limited periods to control their gum disease. In terms of a toothbrush, advise the patients that this should have a small head with medium bristles and should be replaced at least every 3 months, sooner if the bristles are frayed. Most people use toothbrushes which are far too big for their mouths. Foam swabs or cleansers can be useful if the mouth is very dry and sore. In terms of dental treatment, close liaison with the dentist is essential. This will help determine the best timing for treatment. Consider any bleeding tendency, particularly avoiding days when the patient is dialysing. Vascular access and taking blood pressure on the arm, which is important for dialysis, should be avoided. Of course, patients may feel tired, and in those cases, short visits are essential. The dentist needs to be aware of the cause of CKD, as diabetes and hypertension and associated risk factors in delivery of dental treatment should be considered. In view of all these signs and symptoms in relation to renal disease, there is a real focus to prevent oral disease and undertake screening. Many countries have introduced oral screening tools for non-dental professionals. A recent tool introduced by Health Education England is Mouthcare Matters. Resources include posters and diagrams and pictures which help illustrate what a healthy mouth is like and what to do if signs and symptoms of lesions are detected. Essential tools for screening include a small-headed toothbrush, a dry mouth gel, non-foaming toothpaste, and a named denture pot available for the patients should they need them. A systematic approach to screening is advisable, starting on the lips outside the mouth, then proceeding to the tongue, teeth and gums, cheek, palate, and under the tongue. If they are dentures, these should be removed and examined. In terms of the lips, normal lips are pink and moist, but if they appear cracked, particularly if they're swollen or ulcerated, advice should be given regarding management. If the lesions are very severe, a doctor should be consulted. The tongue can appear pink and moist in a patient with no oral lesions, but as the oral saliva reduces, it becomes dry, fissured, and shiny. If it is coated, sore, ulcerated, oral malignancy or lesions need to be excluded. The teeth and gums in a healthy patient should appear glossy, pink, stippled, and firm. In a patient with gum disease, deposits may be visible and the gum is swollen and red. A decayed tooth often looks discolored or black, and on occasion the crown of the tooth may fracture off due to dental decay. The cheek, palates, and under the tongue also need to be examined. A healthy mouth has clean appearance with saliva present, but if it is sticky and dry with ulcers, or if those ulcers now start to spread and proceed to the back of the mouth, then consultation with the doctor is critical. The denture should also be examined. The inside of the denture can act as a reservoir for fungal infections. If the denture is removed from the mouth, do not store it in a tissue paper, as this is the most common reason why dentures are discarded. In terms of how to clean the teeth and how to clean the denture should be cleaned over a basin of water, so that if it slips from the hand, it does not fracture. It should be dried and stored in a denture pot, which is named. The patient should never wear the denture at night. They should clean the denture both on the inside and outside surfaces. If oral thrush or candida is present, the patient should soak their denture in chlorhexidine mouthwash for 15 minutes twice daily, rinse thoroughly, and leave the denture out as much as possible until the mouth heals. In conclusion, we can see that at least 90% of patients with chronic kidney disease may have oral complaints or lesions within their mouth. These may involve jawbone changes and mucosal lesions, and growth and development of the jaw and teeth may be affected. It's important to discuss and be aware of the impact of CKD on dental decay and gum disease, particularly the high incidence of a dry mouth. Prevention and screening strategies are essential, as many patients do not see a dentist. Where a dentist is present, it's important to liaise closely with them to discuss how delivery of dental treatment may need to be modified. Let's return to the two cases that we discussed earlier. For this patient with a sore mouth, they have in fact got uremic stomatitis. We've learnt that although this is rare, it is very painful. If a pseudomembranous variety is present, the plaque may detach and obstruct the airway. It's important to prevent secondary infection through the mucosal barrier. It's also important to control pain, possibly with a mouthwash such as benzidamine hydrochloride. Control of urea levels will help these lesions to resolve and should be a focus of management. When urea levels fall, these lesions should resolve within 2 to 3 weeks. In the second patient with a very dry mouth, it's important to consider that some saliva substitutes should not be used in a patient who is dentate, as they are very acidic and also do not contain fluoride. The impact of a dry mouth on a patient in terms of nutrition and quality of life should be considered. They must avoid having sweet drinks and sucking on sweets, as these can increase the risk of dental decay.
To wrap up the session, here are 4 key points to remember. 1. Chronic kidney disease can give rise to a wide range of oral manifestations. 2. Poor oral health can lead to malnutrition. 3. Proper oral care can prevent complications and improve patients' quality of life. 4. We should raise awareness on the importance of oral care among patients and healthcare professionals.